Hello, my name is Daniel Lopez, and I'm going to present you the paper on Marchiafava-Bignami Disease and the effects it has on gait abnormalities. So for this presentation, I'm going to go over a patient that we had at the clinic. She was 76 years old, and she presented to physical therapy with gait abnormalities. That's what the referral was about. But it was mentioned within the referral something about Marchiafava-Bignami disease, right? So the physical therapist and I were trying to figure out what exactly that was. He knew how to treat it, he just didn't know what exactly the disease was about. So just a brief summary of the case is, just like I said, she's a 76-year-old patient presented to physical therapy with gait abnormalities. All right, she has a history of back surgery last year, a laminectomy. She mentioned right away that this disease is usually associated with alcoholism. Right, it seemed like she just wanted to make it clear that she didn't have this disease because of alcoholism. And after some research that I did, this disease is primarily found within people that are alcoholics, extreme alcoholics, but in rare cases it happens. There is an onset with people that are not necessarily alcoholics. It's just a genetic thing or something that happens within the brain that is uncontrollable. So she was presented with, like I said, gait abnormalities, forward trunk posture, weakness in the lower extremities, and yeah, some of the clinical characteristics. Those are some of the clinical characteristics. Like I said, she had a laminectomy. She asked the doctor if this disease or her gait abnormalities were just directly affected, directly due to the surgery that she had. They did studies and blood work and everything. They said it wasn't associated with that surgery. Some of her physical history. I asked her if she was physically active at one point. She said she was before the surgery, that she had the back surgery, and after that, that's when she started living a sedentary lifestyle. She has a history of fibromyalgia, osteoporosis, osteoarthritis, chronic obstructive pulmonary disease, gastroesophageal reflux disease, and she's also pre-diabetic. So she's dealing with a plethora of medical issues, and something that needs to be looked at and taken into consideration for when it comes down to some therapeutic exercises that we prescribe her as physical therapist assistants. So some of the examination findings are that we asked her multiple open-ended questions. Questions that weren't just yes or no, just questions where she could go into detail with her answers, just so we could get a deeper understanding of where she's at, her symptoms, and just all that. Right. So she had a lot of weakness at her hip extensors and flexors, and she also with her balance. Right. So we did a lot of balance tests, her Romberg tests, her Romberg scores for just open eyes and closed with their feet side to side. Those were good. They met the minimum 30 seconds for standing still. Her sharpened Romberg were the ones that were a little kind of shaky. So her right leg in front of her left leg was a 10-second hold, and her left leg in front of her right leg was a 22-second hold, and that just shows that her static balance, and when it comes down to gait, it's greatly affected. Right? So like I said, the minimum is 30 seconds. That's the minimum like passing score essentially. So that was something that right away we took notice and we documented. We made sure that was something that was going to be addressed when it came down to her therapeutic exercises. just overall, we concluded that her lower extremity strength was something that needed to be worked on. Was something, yeah, for sure, that was something that needed to be worked on, and was going to be included in the physical therapist's plan of care, and was going to be a focal point for her treatment. Um, just same. So she mentioned that side to side head movements were something that she struggled with. So she did a lot of eye movements. So that's something we took. We also took note. We wrote in the assessment, the medical history, just the overall subjective of that initial evaluation, just so that other therapists that were going to be working with her just took note, right? So she mentioned that she also was really sensitive to light and noises around her. So there were certain points, right? Her initial evaluation was the first week of my clinical experience, and her last session was, the last session that I saw her was the week before the last week of my clinical experience. So the last session that I saw her, she asked us if she could be in a isolated room by herself, lights dimmed down, just because her sensitivity levels were pretty high. She just loud noise around her was bothering her. Just the light around her was bothering her, so she wanted to see if she could do some of the exercises within the room, dim light. Right? So we accommodated her with that, and she was able to perform those exercises thoroughly. But as we progressed through those weeks, we did notice that there was an improvements within her tests and her exercises as she eventually grew independent, not fully independent, but more independent than what she was at the beginning. So she still had to do a lot of the exercises. When she was fine, she was able to do some of the exercises within the parallel bars independently. Sit-to stands, they did involve a little bit of head movement, but it wasn't as drastic as, let's say, step-ups or dynamic movements like squats into both tosses onto a trampoline. So, like I said, she was growing independence, trying to get back to her previous self before the surgery, of being active and just being able to perform activities of daily living independently. Let's see. So some of the examination findings included, like I said, no, actually. So some of the interventions that we, the PT and myself, just went through with her were just to strengthen and increase strength at her lower extremities, in specific her hip extensors. Increasing her strength at the hip extensors, so gluteus medius, maximus, hip flexors, just everything within that area. That was something that was going to help her with her balance, with the overall balance. So that was something that we made sure that we were going to address. So sit-to stands, like mentioned, mini squats, were things that weren't going to maximize her head movements. Standing hip abduction, extension, just to specifically target the gluteus medius and gluteus maximus. If that was going to be an issue, we were able to adjust, right? So seated exercises such as seated clamshells, seated marches, banded resisted seated marching, and clamshells, supine clamshells, supine marches, a lot of just core exercises as well. Just like I said, just to strengthen everything up. Forward trunk posture, abdominals were weak, so we just wanted to do a lot of core exercises as well. So like I said, there were different ways that we could adjust, just to make sure that she was safe and she didn't have that fear of falling. Some of the modalities included that the physical therapist included were electrostimulation, cryotherapy, and hot packs, all in efforts to reduce pain, discomfort. Right? It just all again depended on the patient and her preference. Some days she wanted ice, some days she wanted heat. Some days she didn't want either one, just wanted electrostimulation. So again, it just depended on her preference. So pain relief, decreasing inflammation, increasing blood flow, improving tissue healing were all reasons why the physical therapy included those specific modalities for this specific patient. Right? So specific electrostimulations modalities such as TENS and MES were all included to either re-educate muscle activity or provide patient relief. Right? So so those are some of the interventions that were included by the physical therapist in the plan of care. The outcome we pretty much came up with. So throughout the course of the treatment, there were many instances where we felt that the patient wasn't progressing, but just slowly compared to where she was at the first session to the last one that we saw her at. There was a progression. It was slow, but there was a progression. Right? Even the patient herself said that she felt like her legs were getting stronger. She was able to just more confidently walk throughout her home, perform more activities of daily living, and just not have that fear of falling the way she did before attending physical therapy. The ways that we were able to visually see where she was throughout her sessions were using the visual analog scale. Right, so the visual analog scale, so you just kind of see how her facial reactions, her body reactions were throughout the exercises, throughout the balancing exercises, strengthening exercises, and the modalities. Right, so this allowed the PT and the PTAs to just determine where she was at, how she was feeling throughout her sessions, throughout her just her interventions. Right, so. So balance tests, again, like I said, were performed almost every session, just at least whether it's one exercise, one set, 3 sets of 10, 4 sets, whatever the case was for that day. Balancing was something that was a main focal point throughout her sessions, to go along with strengthening, of course. Her standing tolerance was also another thing that was improving, right? She did mention in her initial evaluation that her cardiovascular endurance wasn't the best. She also wanted to work on that. She also, one of her goals was just to be able to do things throughout the house, right? Just to be more active, not live a sedentary lifestyle. And to be fair, she was an actually really tall lady, thin, so you could tell that she was an active person. She said she played sports, went to the gym pretty regularly, right? So as the patient continued, right, the progression was continued as well, and the focal point, like I said, it was balanced strength, and it was tolerated well. The times that it wasn't tolerated was when she was just feeling too dizzy or just not feeling well, and that's when we would send her into a room that was isolated where we could adjust the lighting for her, and there she could be alone, away from all the noise and the ruckus within the clinic. The patient was provided home exercises to do. So because at home she lived alone, a lot of exercises that were included were exercises where she could be safe. So like seated clamshells, seated marches, supine clamshells, supine marches, a lot of core activities where there wasn't going to be that risk of falling. Right? If she felt comfortable, depending on how she felt throughout her days at home, that's when she would be able to do the standing hip abduction, standing hip extension, standing marches, all those other exercises, including balancing, right? Exercises that she could do on her own where she felt like she was going to be in a safe position. So the appropriateness of the treatments. So as far as the appropriate for treatments, just based off of the exercises that we were giving her, the treatments that she was going through were going to definitely affect her overall outcome of this disease. So like this disease, it wasn't going to be reversed. It was just going to be controlled, right? So there's 3 stages with this disease. There's a chronic, subacute, and acute phase. So the acute phase is strictly the Marchiafava-Bignami disease. So with that disease, you're essentially just going to just take sudden declines in health, right? Sudden declines in gait, in strength, everything, because it's going to be affecting those brain hemispheres so much so that you're not going to be control your movements, your muscle activity, and all that. Subacute, which I felt like she was in, she was able to control gait, she was able to control mood, but it was greatly affected. Chronic phase, that's where the disease is probably associated with another disease, right? So the symptoms weren't going to be as strong, as affected. So all these exercises, the treatments, modalities, everything was essentially just to control her symptoms, not to reverse the disease, right? So the effectiveness of the treatments were also noticed as she was progressing. She was getting stronger. She was being able to walk more smooth throughout the clinic. As she entered the clinic, left the clinic, she has said herself that she was able to feel the strength within her lower extremities, felt that her balance was increasing. Right, the patient, her safety was another big thing, as mentioned. We were able to adjust the exercises whether she felt unsafe or safe. Seated, supine, standing, those are all different options that she was given, just depending on how she felt with her safety. Right? And the therapy outcomes were another thing that, that's like I said, this disease is irreversible. So we were just there just to control her symptoms, improve her gait abnormalities, improve strength, everything, in order for her to be able to live more of a normal lifestyle, to be able to participate in activities of daily living rather than just live a sedentary lifestyle, which is something that she definitely didn't want, as she mentioned her very first day of the initial evaluation. All right, so as far as the reflection, this presentation, so for pretty much for this case study, something that I learned was just understanding that a lot of the exercises that we are prescribing for patients, a lot of the therapeutic interventions aren't necessarily to just completely get rid of issues, right? There are multiple patients that we dealt with different diseases that we were there just to control their symptoms, to pretty much strengthen their lower extremities, upper extremities, but just to allow them to be able to function just properly on a day-to-day basis, right? And that was the case with this patient with this disease. Like mentioned, it's pretty much just it's not pretty much, it is irreversible. So the cells within those brain lobes are dying, right? So it's sad to say, but it's almost a matter of time of when that time's going to come where she's not going to have brain cells where she's going to be able to function or be able to walk, right? So if there is another patient similar to this patient or this disease, I feel personally that I will be able to understand how and why I am prescribing exercises for them, right? So I'd feel like I'd have that general understanding and a pretty good understanding of how to control symptoms, how to control pain and their dizziness, their discomfort, their issues that arise, specifically with this disease of the Marchiafava-Bignami disease. And as far as something that was pretty helpful, something that pretty much just allowed me to just have a deeper understanding of this case overall was, like I said, just being able to control symptoms but not reversing, and improve symptoms but not reversing the disease or what they were presented for, right? So that's something that I found really, really helpful in understanding for future patients, right? I feel like there was also enough literature. There wasn't necessarily like a lot, like as far compared to like cardiovascular disease, constructive COPD, things like that, because it's not such a common disease. All right, so this disease is pretty rare. It's only really seen in alcoholism, extreme alcoholism. Sometimes, in rare cases, it's seen with patients that aren't even associated with disease with alcoholism. So there wasn't as much literature or research with this specific disease, but enough for me to gain a better understanding, enough of an understanding for that specific patient to want to reach out to me in the future to inform her more so about her disease and how she can approach it, how she could deal with it. Right. So that, in a nutshell, I know it's pretty long, but that in a nutshell is my presentation of Marchiafava-Bignami disease and the effects it has on gait abnormalities. Thank you.